Good morning. First, thank you for the opportunity to talk about the Katsina project in Nigeria. Today, I will discuss in-hospital mortality by severe acute malnutrition diagnostic category among children aged 6 to 59 months within the Katsina nutrition program. Katsina is a heavily populated region in the northwest of Nigeria and borders Niger. Frequent outbreaks, conflict between herders and farmers, and reduced access to fields, as well as healthcare, all contribute to the nutritional situation in the region. In 2021, MSF projects in Niger observed an increase in patients coming from Nigeria, and the MSF nutrition project in Katsina opened soon thereafter. So what do we mean when we refer to diagnostic criteria for acute malnutrition? 3 criteria are currently considered. Weight for height Z-score. This index compares a child's weight to the median weight of children of the same height and sex in a reference population. Middle upper arm circumference, or MUAC. And Kwashiorkor, the presence of nutritional edema. The definition of severe acute malnutrition, or SAM, is a weight for height Z-score less than -3, and or a MUAC less than 115 millimeters, and or the presence of nutritional edema, Kwashiorkor. In June 2022, a household nutrition survey in the catchment area of the Katsina project was conducted to estimate prevalence of global acute malnutrition, or GAM, and severe acute malnutrition, or SAM, among children 6 to 59 months. The SAM prevalence was 3.9% based on weight for height, 2.5% based on MUAC, and 5.2% combined. The circles displayed here represent the number of children diagnosed by SAM by either weight for height, MUAC, or in the overlapping areas, both criteria. Among children identified as SAM in the survey, 21% of the children were classified as SAM with both criteria, and more than half were classified as SAM with only the weight for height Z-score. These results indicate that there is a low concordance between the 2 criteria in the Katsina population. Looking at global acute malnutrition, prevalence was 18.9% according to weight for height, 11.4% according to MUAC, and 22.5% combined. So we see a similar low concordance among GAM cases based on these 2 criteria. The survey gives us an idea of the situation in the general population, but now let's look a little bit further into the nutrition program itself. In 2022, the Katsina project consisted of 6 ambulatory structures and 2 inpatient structures. Approximately 100,000 children were admitted across the program. At the peak, more than 3,000 children were being admitted per week. The Katsina project uses simplified admission criteria in the ambulatory facilities based primarily on MUAC and or edema. At the project start, the MUAC cutoff was less than 120 millimeters. In response to this nutritional peak in 2022, certain facilities reduced the cutoff to include only SAM children. In the 2 inpatient facilities, there was more than 13,000 admissions in total in 2022. Inpatient admission criteria includes MUAC, weight for height, and or edema. So in order to identify children at higher risk in this cohort, we aim to evaluate outcomes of children according to their SAM diagnostic category at hospital admission. To do this, we calculated case fatality rates and relative risks according to combinations of the 3 different criteria: MUAC, weight for height, and edema. Marasmic children refers to malnourished children identified by MUAC or weight for height criteria. Kwashiorkor, as stated previously, is a form of malnutrition associated with edema. Today we will focus on hospitalized children 6 to 59 months with SAM admitted in 2022. The analysis was done using programmatic lineless data. So in total, 12,771 SAM children were included in our analysis. Within this cohort, there were slightly more males, and the age breakdown was evenly split between children aged 6 to 23 months and 24 to 59 months. 70% of the admitted children were marasmic, 9% Kwashiorkor, and 21% marasmic Kwashiorkor. The last group refers to children with both types of malnutrition. The overall case fatality rate in 2022 among SAM patients was 8%. So we present here the case fatality rates according to diagnostic category: marasmic Kwashiorkor and marasmic Kwashiorkor. Among those children, hospitalized children with both types of malnutrition, in dark blue on the right side of the graph, had a significantly higher CFR than the other two categories, followed by the children with marasmus with the second highest. Now let's take a deeper look at this information. Here we present the CFR among children with different subcategories of marasmus. Starting on the left, we have children diagnosed with, we have the CFR based on MUAC alone, followed by weight for height alone, and on the right side, children identified with MUAC and weight for height together. The relative risks according to the specific criteria are presented with children admitted by MUAC criteria alone as the reference group. We observe that children SAM by weight for height Z-score alone had 2.2 times the risk of death compared to children SAM by MUAC alone. Children with marasmus by both MUAC and weight for height Z-score had 2.8 times the risk compared to children SAM by MUAC alone. Now we add here children with Kwashiorkor alone and in combination with other criteria. We observed that Kwashiorkor children with low weight for height Z-score had very high risk of death, 6.2 times the risk of SAM by MUAC, of children SAM by MUAC alone. Among children with all three criteria, we see an also elevated CFR of 4.2 times the risk compared to children by MUAC alone. Now let's explore by age. Overall, we observe a CFR among SAM children 6 to 23 months of 6.7% and 24 to 59 months of 10.2%. On the right, we present the CFR for children with marasmus, identified by MUAC alone, low weight for height alone, or both criteria, all stratified by age. Among children with marasmus, the CFR is higher among older children, 24 to 59 months, compared to children 6 to 23 months, across the different subcategories. Kwashiorkor and marasmic Kwashiorkor children are not shown here, but we observe no difference by age within each of these categories. Now let's explore the case fatality rates in the cohort according to different MUAC cutoffs. Here we show two categories that we have already seen: children admitted with SAM by MUAC alone and SAM by weight for height alone. For this second group, this means by definition that the children were admitted with a MUAC more than or equal to 115. Now we have added categories looking at CFR based on higher MUAC thresholds, taking each time smaller subsets of the same children. The third column looks at children admitted by weight for height alone and who were admitted with a MUAC more than or equal to 120 millimeters. The column on the far right includes again children with low weight for height and who were admitted with a MUAC more than or equal to 125 millimeters. We observe that among children with a low weight for height, there is a high risk of mortality even with a MUAC more than or equal to 120 and 125. And finally, we stratified the case fatality rate by stunting status. Stunting, or low height for age, refers to chronic undernutrition and has often been hypothesized to be an aggravating factor for mortality among acutely malnourished children. Overall, 68% of the children included in this analysis were severely stunted. The case fatality rate is similar among those not stunted, moderately stunted, and severely stunted. Our conclusions are the following. We found that marasmus children admitted by weight for height alone had 2.2 times the risk of death compared to marasmus children by MUAC alone. The risk of death was 6.2 times higher among children admitted with low weight for height and Kwashiorkor compared to children admitted with MUAC alone. We observed that children 24 to 59 months old with marasmus are at a higher risk of death compared to children 6 to 23 months among this cohort. Among children with weight for height score less than -3, there was a high risk of mortality even among children with a MUAC at admission above 120 and 125. Stunting does not increase risk of death in this cohort during their stay. Our findings suggest that children hospitalized in the Katsina cohort with low weight for height are at higher risk of death and need some special consideration. While our findings are for a specific cohort with simplified admission criteria, careful consideration should be made before dropping weight for height in MSF nutrition programs. Finally, I would like to thank all the people without which this work would not be possible, including Mathilde and Emmanuel Grelati, Joyce and Philip, who are the field epidemiologists in Katsina and the data teams, the rest of the Katsina, Abuja, and Paris teams, the Katsina State Healthcare Agency, as well as the Katsina patients and families who have attended the nutrition program. Thank you very much for your attention.